I want to talk about getting along on scene a little bit. I want to get some nursing perspective. This is kind of a good group to talk about giving a report in the hospital, stuff like that. So we'll just start by everybody just introducing your first name, kind of experience, what you do, and then we'll kind of launch into the topic. So if you want to start, Audrianna.
Yeah. My name is Audrianna. I've been an RN for 7.5 years now, and 5 of those have been down in the ED, 2 of those inpatient.
Nice.
I'm Alex. This month actually marks 10 years. 10 full years in EMS. So
full decade.
I know. It's crazy.
And you've done private ambulance.
Private ambulance, now technically a firefighter paramedic for a county organization.
Nice.
Can you reach behind his ears, see if they're still wet? I think they're still wet.
They don't smell new anymore.
I don't know, a decade.
That new car smells weird.
I'm Casey. I'm a paramedic. I've been doing this, you said 10 years?
10. That's a 1 and a 0.
Yeah.
I know you're going to trump me with your 500.
It'll be August 10th. It'll be 49 years this year.
We don't mention Trump. This is a non-political podcast.
No.
He meant the Trump, like, card.
Oh,
card.
okay.
No, the Trump card.
Okay. Just want to make sure. Okay.
I'm Micah. I've been a paramedic for only 7 years.
Dang.
He's a bee.
Practically a newbie.
Yeah.
You've been a paramedic now?
No, not a paramedic. I've been
Just
in
been
EMS
in
for 7 years. I've been a paramedic for 5.
Okay. I mean, that's pretty. I mean, 5 years as a paramedic is, you've seen a lot of shit in 5 years, especially in our system.
Yep.
And I've at least had like a little bit of also working a little bit in county fire department and in the hospital as well.
Yeah, that's good, well-rounded experience. You're kind of navigating the paramedic in the ER role, which is always a little bit kind of new, and I think we're trying to develop that a little bit more, but it's kind of an odd role.
I'm enjoying it so far.
Good. Let's start by, I kind of want to get Audrianna's perspective on kind of getting report from EMS and stuff like that. Like, what's stuff from the nursing side that you like to get from the EMS crews and their reports?
Really just a clear and concise report. So all the pertinent things, if you gave meds, vitals, even mobility when you picked a patient up, if you had to carry them down the stairs, if they were, waiting on the porch for you. But really just that stuff quickly, unless they are unable to speak for themselves, then I expect a little bit more in-depth report. But we're going to ask patients pretty much everything we asked you to, so it's really nice to just get it clear and concise, and then that way I can start my patient care.
And on the nursing side too, you guys care more than the providers do about like fall risk, because you've got to figure out if the patient needs to go to the bathroom, how are we doing that? I feel like on the provider side, we're less focused on that. We kind of leave that to you guys. So I feel like their ability to ambulate is a big thing that you guys probably want to get more specifics on maybe than we care about on the provider side, because you've got to figure out those logistics,
Yeah, for sure. Getting bed alarms set up on them, whether or not we're going to have to use a bedpan versus get them over to the bathroom, getting them over to CT and how that's going to work out. So, yeah, for us, it's a lot more mobility than the providers.
One thing that always annoyed me when I was a paramedic was, I think it's like our adversarial nature, but when the nurse would ask if they have an IV, I would immediately get like self-righteous and be like, no, they don't have an IV. We were just down the street from the ER and I tried and I couldn't get it. And you start giving all these excuses when you're just asking, I just need to know if they have one, because we're probably going to need to start one if you didn't start one. And
yeah,
I think
and certain things we do can't run off of EMS lines, like certain CT scanners can't push the contrast through field lines, so we just asked to know if we're going to have to start an IV. I'm very grateful when I get a patient who already has an IV, because I know I'm going to get my labs in quick, I can get my fluid started quick, so we're very grateful when we do get an IV in the field. But I've never started an IV in the back of a rig, so I totally understand if you can't get one started.
Right, and you're not like judging. I feel like it's just a question. We just need to know yes or no, but I feel like the crews tend to get more, at least I always did, I'd get self-righteous and have to justify why we didn't have one or whatever, when we just need to know if there is one or not.
Yeah,
You missed the ID.
I wouldn't say it was self-righteous. I think it was just one of those, like, do you already know how much I did before I got here?
Right.
Sorry, then I'll have an IV.
We carried them down 4 flights of stairs.
You know?
It's very much our version of inpatient nurses asking us, like, what does their skin look like? And we're like, it's present. I don't know. You know? So,
Covered with it.
yeah. So I totally get it.
Yes. Like,
Everybody has
they
like
have
their
it.
check boxes. Yeah, I have no idea about inpatient nursing, like what things they need to know, and it's funny. Like some of the things are like their skin. Why do you need to know what their skin looks like? Their vital signs are stable.
Yeah.
Their skin's
They're
probably
breathing.
Yeah, their skin's probably perfusing.
Yeah.
Or we may not be having this conversation. What kind of stuff do you guys like to hear from the nurses? I guess from the EMS side of things, is there anything specific?
I just want to be heard.
Yeah.
I think nowadays, I think you see a change from, like when I first started, the nurses didn't understand what we did at all. They thought we just threw them in the back of the ambulance and drove them to the hospital. You know, both of us rode up front. Hey, what's your insurance? You know, that kind of thing. And that was about all the treatment that we did. But I think more times now, since we're out of our infancy in EMS, I think that we're seeing more understanding about what we can do and what we can't do and those kind of things. But every once in a while, you just you get a couple of nurses I can think off of the top of my head that just won't listen to you. But for the most part, they mostly do. And I think that, just the listening part, active listening.
Yeah, and provider side too. I think the providers are better about it. We, as a group culture, like our group's pretty good about saying, hey, we need to give EMS X amount of time, like listen to their report. And I do that even more if they're like a newer crew. You get a new EMT they're really new at giving report. I try to give them plenty of time with the understanding like this is a new thing for them. It's one of the harder tasks as a new EMT is to give a concise report. And so I try to let them stumble through it and then kind of ask the pertinent stuff that they may have missed. But they got to practice, and if you don't give them room to practice and you cut them off after 10 seconds, which would certainly be my tendency, it doesn't do them any good.
Well,
So
you can do the gee whiz stuff that, you can intubate and start the lines, give the drugs and do all that stuff, vent the chest, crike, all that kind of stuff. You got paramedics that are really good at that, and then they come in and they go they fall all over themselves and can't talk, and they get nervous. You've got, especially if it's something big like a big trauma or something, you get nervous and you get tongue tied, and the trauma surgeon stand there looking at you, and the trauma PA stand there, and the nurse practitioner stand there looking at you, and tapping their foot,
right,
and going, hey, let's go, let's get report and stuff. And it's a lot of pressure, I think. But as a general rule, we're in fact seen it more in like the last probably 2 or 3 years that the listening is listening to our reports has gotten much better on the provider and nurse side than it was before.
We almost do like a timeout kind of thing right when we first get there. Everybody kind of is like, which has definitely helped from the beginning, the first few times I brought in, and you're just like so overwhelmed because you hear everybody doing the things, and you're just like, do you want my report now?
Yeah, especially with the critical patients, because you got multiple nurses in the trauma bay. Some of them may or may not, correct me if I'm wrong, Audrianna, but some of them may or may not really care that much about the report. They're more task-oriented nurses as opposed to
For sure.
the primary nurse on that patient. So they're more like, let's facilitate getting the patient over, let's make sure we have IVs, start doing exams and stuff like that, getting labs drawn. And so they're focused on moving the patient over and not really listening to the story. Like, do we want to move the patient right over? Do we need to make sure they're stable, make sure the IO is not going to get yanked, or if they're getting paced, the pacer pads stay on them. And so sometimes just the ones that are more task oriented, the techs, the nurses that aren't primary on that patient are like, let's just move them over. And that pause to be like, are we safe to move over? Let's maybe get a report before we move them over, kind of stuff.
I think that's changed as well. I think that I've barked at a lot of people. in my day, telling them to wait. Let me, because I know what's going on with the patient. I know what IVs are where. I know those things. And I've had more than a couple of IVs pulled that were hard fought for. And, and just because of, having to get the patient from that pram to the stretcher and, to the hospital bed, and things getting, pulled or whatever, and, taken off of a pacemaker.
Yeah.
And the patient go, and
Yep.
you can't get it back.
Right.
So, but that's kind of changed, especially in the critical setting. We tend not to move them until the paramedic says, move.
Yeah.
Dr. Kosh was saying sometimes he'll stand between the hospital bed and the pram to make sure things don't happen before he's ready for them to happen. People are like, get out of the way, we need to move them over. He's like, hold on, they're stable. Let's get report, and then we'll move them over. And
Have some people accidentally extubated because everyone's eager to get them over to our ER stretchers. And I'm like, is EMS ready first? Because they're the ones who have all of the tubing and connections on their side.
Yeah.
So.
Or sometimes the seatbelts are still on and they'll just like,
Yeah.
I've almost had them pull the cot over.
Yeah.
Yep.
That's going to leave a mark.
they ain't going anywhere if there's still a seatbelt attached.
Yeah.
So sometimes it's just like, it's worth to take that second, take a deep breath and be like, hey, let's just make sure we're all on the same page.
Yeah.
Everything's all sorted out. And then I can go back and give my report, or I can give my report while my partner is helping me out getting everything moved over.
Well, it builds the team too. It builds trust in each other, and before, because when all that would happen and something would get pulled or yanked or whatever, it built animosity. And it's like, I don't want to bring somebody to this person. And now when something like that happens, it's truly an accident. I mean, it's a rare case that it happens, and I think we're a little kinder, gentler since we've built that kind of rapport.
Yeah. And I think when you're, like the private ambulance service historically always has high turnover, so it's hard when you don't know the crews, you don't know their names. In the ER, and you've probably seen this a little bit now, Micah, being in the ER, I feel like we're very team-oriented in the ER. We all work with each other every day. We all know each other's temperaments. If somebody says a short remark, usually we don't take it personal because you know that person. You know that, we're just in a hurry. We don't mean to offend each other. And so you can take those things with a little more grace versus the crews or the cowboys. They're coming from the outside world. They're not with us every day. I may not know their name. So it's important to build that team and include them as a team. Since they're kind of coming from the outside world, it's you and your partner against the world a lot of times on the ambulance, and so incorporating them into our team I think is key. And the people that stick around longer, it's easier to do that because you know their names, you've gotten report from them a bunch of times, and things like that.
And I agree, like it's been an interesting thing seeing it from that side, like having like a stroke alert coming in and you're just waiting in the recess bay, and to watch them come in and give the report and see that like nervousness where it's like I'm just thinking about, I'm either going to draw labs, I'm going to get another IV, I'm going to get a manual blood pressure, I'm going to do like the task that I was assigned, versus like being in that side and bringing them in, having to be ready to give report and say all the things that have been going on with this patient. So, and helping them kind of like be included is like, I do agree, it's helping build that like camaraderie.
Definitely say it's been different coming from the private system where I was running a lot more calls, and now working at this county system where I'll work a 48-hour shift and run, average like 6 or 8 calls. And then even then, some of them, you transport maybe 5 of them. So now I'm finding myself when, working for a private company in 12 hours being at the hospital 10 to 12 times to in 48 hours being there maybe once or twice. And so then there's that kind of aspect where some people are like, well, this nurse and that nurse. And I'm like, but I remember when I was working with them, like, you just got to be like, you got to think about them too. We're not there all the time. We don't see how continuously busy. I think for me, coming from the larger system going to a slower system has given me, I guess you could say, that grace to be like, when you get there and they're a little moody or something like that, I know what it's like when it's busy.
Mm-hmm.
I know what it's like when it's there, versus these people that kind of grow up in these slower systems that are just like, well, why are they acting that way?
Yeah.
And I'm like, well, because they've had 40 patients, and
Yeah.
not all of them have been the best patients
Yeah.
you've ever seen.
Yeah.
You know?
Well, and the nurse you're giving a report to also has several other patients simultaneously. I think it's being on the provider side, I see like why the providers have such a short attention span now, because I'm like thinking about the 12 other patients I'm trying to handle, and I'm trying to get this one all set up, get the orders in. You know, I got to go talk to them again after getting a report. And so like all these things are running through my mind, and I kind of understand why some of the physicians or PAs or NPs you're giving report to seem to have such a short attention span. It's because they're also thinking about 12 other patients they have. And the nurses, too, are also thinking about, I got to go give meds to this patient. They're trying to dispo people. They've got a
This
bunch
is
of
my
other...
5th ambulance for the day. Why is no one else getting an ambulance? How do I get this person out of here because they came by ambulance? Their family's not here to get them.
Yeah.
So you're forward thinking as far as like when the disposition happens, how am I going to get this person home?
Right.
If they're, going back to a nursing home, much easier. We have...
Or if it's even a place for them to be able to go home to.
Right.
Like, where are they coming from? Is this home appropriate? Because of the reason why they're here, do they not have care, to even go to that home?
Right.
Those are things that you guys have to think about. That me on an ambulance, I'm like, here you go. Here's my patient.
Yeah.
And, that's kind of it for me. I mean, a reason why I enjoy this side, though, too.
Yeah.
And I think the nurses, they just get their asses handed to them. They do.
Yeah.
And I mean, we run shifts where you run a 1.0 unit hour utilization. I know most people don't know what that means, but that means for every hour that you're running a call every hour. So if you work a 12-hour shift and run a 1.0 unit hour utilization, you're running a call every hour. You're taking a patient every hour. 12 patients in a 12-hour shift on an ambulance is a lot.
Mm-hmm.
And so I don't think that a lot of paramedics understand how beat down nurses get, because we've talked about Eric in past on the show, and he's fairly well known in the system, and he was a paramedic for us, and then became a nurse, was a flight nurse. Now he's a nurse practitioner and stuff. But he told me after he went to nursing school and did all his clinicals and stuff, he told me, he goes, I will never shit talk a nurse again for not doing anything. And me thinking that they don't do anything but just walk around and talk to patients all day. He goes, they are on their feet constantly all day long.
How many
They
patients
never get
do you
a
think
break.
in our busier centers, like how many patients do you think a nurse averages in 12 hours?
Oh, gosh. A lot of variable factors, but I would say each nurse probably goes through at least 20 in just a 1-hour shift. And that's just as a night shift, or for day shift, probably way more than that. Because they're working on so much more throughput. You have more patients that could get to surgery and upstairs quicker because they're discharging quicker. So, probably 20 plus.
It
And
depends
usually-
on what care unit.
What
Yeah.
care unit you're in, what they're there for.
sorry.
If you're in one of our quicker units where we can see more urgent care based things, you're probably seeing double that in your shift.
Yeah. And ideally a nurse has 4 beds at a time, right?
Ideally, yes.
And that's how it's supposed to work, is a 4-bed assignment is kind of what they deem safe,
yeah.
for a nurse. And sometimes maybe that changes, but it probably shouldn't.
Yeah, and you
But-
always hope in your 4-bed assignment someone doesn't wind up on a drip of some sort, because
Right.
that cuts down your time you can spend with someone else as well.
Well,
Yeah.
you guys are also having, just bringing in patients and talking to nurses, an increase of boarding patients, which is you're actually like housing the patients in the ER. So not only are you having to do the quick kind of care of an ER, but you're also having to be almost a floor nurse sometimes too. And,
Yeah, do full care.
and it's, I couldn't fathom that, I do my 12 patients and I go home, like,
Yeah.
there's once one room empties, you're kind of like, oh man, here comes another one. Like, it just keeps filling up. And then hopefully, like, if you have to board, could be boarding 2 or 3 patients at once, and
Yeah.
then you're continuous care. So It's definitely a job I don't envy. I'll tell you that much.
Yeah, boarding's a tricky problem we deal with, which I think our system's better about it than a lot. I mean, I've heard some systems in like Texas and stuff. I mean, some hospitals board a lot heavier than ours does. But I mean, that's a tricky situation for the nurses. Then they're coordinating with the inpatient physician as opposed to the ER physician. But a patient might start to crump all of a sudden, and they need to get the emergency physician involved. And coordinate with the hospitalist. It's a trickier position to get in, especially to get orders for somebody who's deteriorating or their status is changing.
And boarding doesn't necessarily mean you're going to get all low acuity patients. You might have 2 of your 4 ICU patients, 1 turnover ER bed, and then 1 low acuity inpatient admission. So you could have a culmination of everything.
And ICU nurses take 2, right? Mm-hmm. So up in the ICU, they're taking care of 2 very high acuity patients. So I can imagine how the workload would get pretty overwhelming in the ER if you're dealing with more ratios than is appropriate, depending on acuity.
So if you're asking if we have an IV, it's just
Please.
No, we were just down the street. They were across the street from the hospital. They were just discharged.
I walked him in here, okay?
Do you know why CAT scan doesn't like using ours?
They
They will use them, but do you know why they don't?
Wait, why they don't like what?
Using our IVs.
Oh.
The locks that we use won't support the
Pressure?
The auto injector.
Yeah.
Oh.
And a lot of them don't like to hand inject contrast.
Yeah. They have to hand inject it through ours because there's so much pressure. They use a specific
Lock set?
And
Do we switch those out a lot?
we used to carry them on the stroke ambulance. We'd carry them because we knew that they were going to get contrast. Well, now they do contrast in the stroke bus itself. But they've got those injectors.
But I mean, something just even as simple, like when I was doing my clinicals, I remember, was it to get for, I'm just deadheading this now, septic patients in order to get cultures. They had to, chlorhexidine or whatever have to be prepped. So that's why they won't use our lines, because they have to be properly prepped prior to getting that draw, and has to be like a fresh stick and stuff like that. Yeah. And I think sometimes prior to knowing that, I was always like, why are they sticking them again? Like, am I not good enough?
Yeah, I did have one
incident
ego. Like that, and I was like, oh, I got to get a new line on this guy who's going to CT for a stroke, and the firefighter was like, our line's good, and I'm like, I'm not saying it's good, just your tubing doesn't work with our machine. I'm sure it's a great line. This is not a personal attack against you. I just have to get a new one.
As soon as I figured that out, that it was like, oh, well, they need a clean stick for cultures, then I was kind of like, oh, okay, you're not asking, do I have a line? You're asking because it is another step. You know,
I do have to do now 2 extra sticks on a person. My
tech now to be like, hey, you need this stuff, you know. And then learning, I think, it had definitely helped me kind of be like less aggressive with them, being like, why didn't you do this? And I'm like, I don't know. Sometimes I'll let you guys have fun too. Just stick 'em.
Well, and I was always taught too on the ambulance, start very peripheral, very distal. You can get a hand IV with a decent gauge, throw it in their hand, and then keep working your way in. Whereas most of the time we're using contrast in the ER, and we need AC and above. You know, we need large bore and more
I remember
proximal.
just even being told a long time ago for just any stroke patients, it was an 18 gauge AC or higher. And when I got to my new system and I was kind of telling them for a stroke patient, I was like, I need an 18 gauge AC or higher. And everybody looked at me like, what are you talking about? And I'm like, it's for contrast purposes. I'm like, well, we don't use anything bigger than 18. I'm like, let me tell you something. A CT person will love a 16 because that contrast will flow amazingly. Yeah. But AC or higher, please. And they're just looking at you like, I guess just not knowing, you know, when they're like, what do you mean? This is what we've always done. Work from the bottom and work your way up, you know.
Which makes sense until you realize what they're utilizing it for.
Yeah.
And I mean, when I was working EMS full time, I don't think I ever really understood that, you know, until I was on the hospital side. But especially if they're coming in by ambulance, they're more likely to need blood cultures. They're probably more likely to need contrasted imaging than maybe somebody that's coming through the front that's much more stable. But is there anything on the nursing side that you think the crews don't know about nursing, or that or at least some of them may not know about nursing that you'd want to convey?
The CT contrast was, of course, an important part. Like the IVs, we're not trying to attack you about them. It's just
Sure.
we just need certain IVs. I know some EMS personnel who bring in people, they get very upset if we're not making eye contact while they're giving report, and that's just because we're so used to like talking while we're doing things and trying to utilize time. So we are listening. It's just we're also trying to get our first set of vitals in, get stuff charted on the computer because charting takes so much time. So a lot of our stuff is just trying to maximize the amount of time that we have for things. So it's not really like I'm not paying attention to you. I'm just trying to multitask as much as I can of what I'm doing, especially if I'm the only staff member in the room other than the physician who's trying to get all of this done.
Let me make a comment about the charting. The charting is so much different on the ambulance versus the hospital. Epic is like so in depth and just sitting there trying to stare and make through all of the fluff and all of the extra things versus like what we use in the field. It's like that's like baby's first chart.
Right.
It is.
Baby's first chart.
It is. It's really. Have you used Epic?
I've never had to use that.
Holy
thing,
hell!
so
It's a huge program.
Like even when you're telling me that you gave a liter of normal saline and 4 of Zofran and 4 of morphine, I have to put that in the chart. Like there's a location in the chart for me to chart that. When you give me pre-hospital vitals, there's a location in the chart for me to chart that. So there's just, when you're telling me these things, I'm trying to remember it in enough time to make sure it gets in my chart, in addition to everything else that I'm charting and my orders and triage note and such. So.
I have a question for you.
May I have an answer?
Do you guys customize your Epic?
Yes.
You guys can do that? Because I know the providers do that, and we used to do it on the MSTU. You could set it up the way you wanted to do it with like this, in the order that you do things and so on and so forth. And I didn't know if you guys could do that as well.
Yeah, all of my EMS stuff is at the very top because that's what I'm getting first, and then my stuff comes later, and very later on is all of my screenings because I'm less concerned about that. I'm more concerned about vitals and how they got here and triage note, and then I get to my more in-depth required stuff.
Yeah, because the system requires the nurses or the paramedics to ask a series of a bunch of other questions, fall risk type stuff. They have to do a suicide screen on every patient, and sometimes they find things in there. I mean, they're in place for a reason. Some patients actually do have some like suicidality that come in for something completely non-related. And so we do help people, I think, in that regard, by catching certain things and are they safe at home, that kind of stuff. And sometimes, they give surprising answers to that and they don't feel safe at home for some reason. And the nurses and the paramedics are catching a lot of that stuff when they're intaking a patient after they're getting all the report from the crew and inputting all that stuff. So they have a lot of stuff to go through. I try not to interrupt the nurses when they're doing that because I feel like some of the nurses, and everybody's typically fine with it. They know the providers are, when I go into a room, they usually give me the grace to be like, okay, you're here now. Let's not make you come back to get the story on the patient. But you are interrupting the nurse. So I try to give them the time to get all the questions answered so they don't also get their workflow interrupted by me popping in at an inconvenient time when I could have waited a couple minutes and now the nurse's intake's done and I can get the report and stuff. But there's a lot of little things like that, I think, that kind of come with experience. You learn not to interrupt other people's workflow, and we all work together pretty well to realize that's going to happen. A lot of times the provider's the limiting factor. So if they can get into a room now, you kind of let them do their thing and go back to it. But
I just need providers to show up when we get there.
Yeah, gosh.
Well, it's something
slackers.
we tried to do too.
You look at them; they're just sitting there doing.
I know, just
nothing.
sitting there on their computer.
Yeah, whatever. I think
just scrolling TikTok.
I think they're playing solitaire.
Exactly.
Yeah.
The nurse is sitting there too, like, just tell me, it's fine.
Yeah.
I'm like,
shopping on Amazon.
we don't need them.
Yeah.
That is one thing I tell the new providers to work on is seeing the crews come in as your highest priority. If you're in the middle of any other task, you can pause to go get report from EMS because often you guys will have critical details the patient will not convey or the patient can't provide. So it's super important to just stop what you're doing and go in, especially because they have the clock's ticking on our length of stay. So they get in, they have no orders in, they have no workup ordered. A provider hasn't seen the patient. So theoretically, that's the highest risk patient in the department is the one that hasn't been seen by a provider. So that should be bumped to the highest priority. If you're in the middle of, consulting a specialist or catching up on charts or whatever you're doing, it's usually worth pausing to go get that report. And I think as a group, our group does a pretty good job, but when it's a busy day, sometimes it just doesn't happen, but it should be moved to the highest priority.
Yeah, there's very few instances where I feel like, hey, I need something on this patient and my provider's nowhere to be found, and there's not many standing orders that nursing staff can do. Typically, when I'm having trouble finding a provider, it's because everything else has gone to hell. You know, EMS is bringing patients in, and I'm trying to get this patient settled, and 3 traumas are going on, so it's all hands on deck there. So
yeah, sometimes EMS hits us with 2 or 3 ambulances at a time, and maybe it's all in one care unit because they're all higher acuity or whatever it might be, and then the provider does get pretty bogged down with that kind of stuff. And we're trying to stay caught up on notes and stuff, which is kind of the lowest priority thing, is to keep your charting updated. You know, getting in orders is the higher priority, especially on the new patients, so things can start getting in process and we can get a plan together. But is there anything on the EMS side you guys think that the nurses don't know?
I think it comes like sometimes when we have those situations where it's like we find patients that we have no idea what's going on with. It's like this person's found down unresponsive in so and so area. Even from nursing homes, half the time it's hard to get information on some of these patients, especially in the middle of the night. These nurses like, or not the nurse, but the QMAP generally is like, I can't access the computer, or
and a QMAP let's define what a QMAP is, because a lot of facilities only have a QMAP, which is
a qualified medication administration personnel. Or personnel.
It's like a week-long course.
Like they're just trained to give the meds.
Yeah.
That's it.
Like they don't really know what they're for necessarily. And
they just read the label, make sure the patient gets the right dose at the right time, right route.
Yeah. And that is probably something that the hospital doesn't know a lot of times, is that's who's giving your report, and maybe who called the ambulance. They don't really know a lot of medicine. They know what meds the patient's on, and that's kind of what you get.
I think it's just that understanding. It's like, I'm going to try to give the hospital everything that I could find out about this patient and do my best to convey that. And then if it's like I don't have like X, Y, and Z, maybe like their allergies or something, just because it's like I wasn't able to get it.
Yeah. Sometimes you have to put together the history by the meds that they're taking.
Exactly.
You know, well, they're taking lisinopril. Okay, well, they've got high blood pressure.
Or metformin.
Yeah, So, you know, a lot of times I use the term overall poor historian a lot.
Yeah.
It seems, and